I've been asked to talk about CMS guidelines for sale. And this has both a personal and a professional aspect to it for me. Yesterday I discussed a little bit that it's important for all of us to be involved in the politics of healthcare as time goes on and discuss these issues with our patients. But with this presentation, I hope to give you some fodder, or more fodder for so doing. We all know commercial bias exists, whether it's in the Texas Medical Board or in the investigations in the literature. It's certainly rampant in the literature. And so the question comes up, how do we read the literature? And do we check the funding sources of the authors? And if not, you should. It's an interesting discussion that I had with some of the medical students that this is almost becoming a lost art in medical school. It was one of the first things that I was taught is when you read the literature, read it critically. But the question is, do the experts read the literature? Now, these experts are often the same people who are influenced by the same dollars. So today I want to review one specific guideline and go over how this particular guideline, I believe, is dishonest. This is the guideline of the American College of Chest Physicians. Now, who are the American College of Chest Physicians? Since the early 1980s, they've been dictating how everybody else is supposed to run their practice. Now, being fair, the 9th edition of the guides, released in February of this year, is somewhat more honest than previous editions. Still not 100% free of bias. But much to my dismay, the CMS has adopted the 8th edition of the guides. So why not the 9th edition? Well, this is the statement that's come out. The Surgical Care Improvement Technical Experts Panel regularly reviews relevant guidelines and has determined in general that only a change with a level 1 recommendation would affect the SCIP performance measures. The current measures, specifications for VTE or venous thromboembolic event prevention are based on level 1A recommendations. Now, the fact that the current ACCP recommendations say there are no level 1 recommendations doesn't seem to bother the CMS. Now, this is on a t-shirt that my son has. Thus, to the government, there are two types of doctors. There are compliant doctors who do all the paperwork and are interchangeable. And then there are bad doctors. Now, we've all seen advertisements for conferences such as this one. This particular conference is aimed at business and hospital finance managers. And you notice who's sponsoring it? Sanofi Aventis. Okay? They make the drug. It's not a cheap drug. So let's look at the guidelines from the 8th edition for prevention of DVT. First released in 2008, shortly followed the American Academy of Orthopedic Surgeons releasing their guidelines for the prevention of venous thromboembolic events. And there's a distinction here. We'll go over that a little bit. The major change in the 8th edition from the 7th edition was they now bashed the American Academy of Orthopedic Surgeons. So I'm going to look only at the arthroplasty recommendations. I'm not a cardiologist. I can't comment about whether there's dishonesty in cardiology recommendations for general surgery, etc. I'm going to pick out a couple of the major points made by the ACCP, and I think their work is as significant for what it does not say as for what it does say. Now, how are these recommendations presented to orthopedists? Now, an orthopedic surgeon travels around the country and sponsored at many major talks to discuss how orthopedists see DVT prophylaxis. And he starts with this: orthopedists like it simple, followed by surgery causes blood clots cause embolism, embolism causes death, and death is bad. Now, I don't think that orthopedic surgeons really like it quite this simple, and frankly, I think this is an insult to my intelligence, and I think most of my colleagues as well. I'm going to go back to how you read medical literature. Okay? We're taught Was the study well designed? Was it well executed? Do the results justify the conclusions and the recommendations? And are the results and recommendations relevant to your practice? It should be done for every article you read. Now, like or dislike this particular guy, one thing he says with frequency is, don't take my word for it, do your own research. So if anything I say today you question, look at it yourself. And if you find that I have been inaccurate in any way, please let me know. And I may not be politically correct here. This is not a comment on computers. Now, I think there are several evident faults in the ACCP guidelines. There are inaccurate assertions, faulty logic. I think they turn a blind eye to significant data. And then there's also political posturing. So we'll do a quick critical review of the 8th edition guidelines for arthroplasty patients. First assertion that I looked up was this. VTE is the most common cause for readmission to the hospital following total hip replacement. Okay? There is, I don't see this. Does anybody see this? Not in today's world. So they have, and note this reference though is, this comment is repeated over and over on websites such as this one, where they threaten the surgeon that the monkey on your back is the blood clot and you want to concentrate instead on the surgery. And they say in the bottom here, again, VT is the most common cause for readmission to the hospital. And who is their reference? They have one reference. Now this was not actually a bad study. It was 11,000 patients, a population-based study on patients operated in England. And surgery was done, though, between 1976 and 1985. The study was published in 1991. Okay? There's no mention of prophylaxis given, if any. And back in 1985, when I was in training, we kept total hip replacement patients in bed for only 3 days before letting them out of bed. That was considered aggressive mobilization at the time. So I don't think that a study done and published in 1991 has great relevance to practice today. So insertion number 2, the rates of major bleeding in the placebo groups of other randomized trials, notice the plural, in total hip replacements were similar, 4%. So let's look at that one. Turpie is one of there are 2 studies referenced, Turpie and Colwell. So let's look at Turpie study. This was a small study, 100 patients. 2 patients in the placebo group and 2 patients in the treatment group had significant bleeding episodes. Now, one of the patients in the placebo group had a blood clot, was treated with heparin, had a bleeding episode, and died from that bleeding episode, adrenal hemorrhage. Now, the ACCP regularly belittles small studies, but this is only 100 patients. So let's look at the power analysis. If the placebo group had 4% observation of major bleeding, okay, is this different from 0%? So if you look at 95% confidence intervals and a standard alpha value, you need 74 patients to say that this group is significantly different from 0. Therefore, with only 50 patients, 4% is indistinguishable from 0. Looking at the power analysis a little different way, in order to make a really meaningful statement here, you need a lot of patients. Okay? And there are only 50 patients in the placebo group in this study. So let's look at the other study that's referenced. It was Colwell. It's a large multi-center study, more than 1,900 patients, similar protocols, many groups. Again, only 50 patients in the placebo group. Okay? Now, one of them died from an adrenal hemorrhage from a bleeding complication. Sound familiar? So, now, also Colwell's study was based on intent to treat. In other words, anyone who got 1 dose of the study drug was considered to have had the study drug. Now, to me, this is an easy way to hide complications. If someone has a minor complication after 1 or 2 doses of the drug, then you stop the drug and it's not a major complication. You're saved from listing it. Now, like many of these studies, it excludes high-risk patients. They did non-invasive tests. Of course, the ACCP is very adamant about the gold standard is venography. Now, all tests were verified by venograms, and all patients were supposed to have bilateral venography. But other studies that have been submitted that have this same statement are excluded from consideration. Now, no mention about how many actually had the venograms. So why is it important? Again, because the ACCP says that's one of our standards. Well, they're breaking their own standards. Let's go back to the adrenal hemorrhage. Both were in the placebo group. Both studies were done in Canada. Both Canadian studies lacked venograms on the first 24 patients. Both Canadian studies had 50 patients. And Turpie is from Canada. So effectively, you have to conclude that this study is a subset of the study that Colwell publishes. And so really, it's only one reference instead. So let's look again and revise the statement made. It probably should read better: the major rate of bleeding in this placebo group of the only small other randomized trial, now singular, in total hip replacements was similar at 4%. But if you add back in the discussion about power statement, it reads more like this: the rate of major bleeding in the placebo group of the only small randomized trial in total hip replacement patients was similar. With the limited sample size, the reported rate of 4% is not statistically different from 0. Conversely, with thousands of patients in the treatment arms of chemoprophylactic studies, the rate of major bleeding is clearly defined and is statistically significant. It's even less of an endorsement of chemoprophylaxis. Okay, next assertion. Aspirin and other antiplatelet drugs provide much less protection against embolic events compared with other thromboembolic methods. So let's look at that one. They quote the PEP trial. They claim in this trial that the primary effectiveness outcome in the trial, or vascular death, or primary goal, was to lower vascular death, and it was not significantly reduced by aspirin. This statement's only half true. If you look at the PEP trial and you read it, very clearly stated the primary goal was not the reduction of all vascular deaths. Instead, the primary goal was to confirm or refute the meta-analysis results that aspirin reduced the risk of blood clots and pulmonary embolism in various high-risk groups. And what did they find? They found that there was a significant reduction of fatal PE, but there was no change in all vascular deaths. So what about confounding variables? Another point that the ACCP brings up. The PEP trial does analyze these independently, and the effect of aspirin is still valid in that study. Okay, moving on. If thromboprophylaxis is not used, fatal PE occurs in approximately 1 patient in 300 elective hip replacements. Okay, where did they quote this? They quoted the Dahl study. He states exactly the opposite. The rate cannot be calculated. Now then, this is how we study also, a 10-year population-based study. It's actually a very good study from the Scottish Health Registry, but they make no comment regarding mortality without thromboprophylaxis whatsoever. So in a sense, this is double talk. The ACCP comments, although meta-analyses have shown that thromboprophylaxis with low-dose unfractionated heparin or aspirin is superior to nothing, both agents are less effective than other agents in this high-risk group. Who do they reference? Themselves. Okay, so let's look at aspirin for a minute. Aspirin versus placebo. The antiplatelets trial, okay? It looked for efficacy against all DVT, who said it was moderate, not specified as symptomatic versus asymptomatic, but more importantly, the efficacy for fatal pulmonary embolism was fantastic, 0.2%. So then next assertion. Coumadin and the like reduce blood clots but are associated with a significant increase in wound hematoma rates. They have 4 references. I love this first one. It's Friedman. He stated there was no difference in fatal pulmonary embolism with multiple different types of prophylaxis. Increased wound complications only with heparins. And in fact, the recommendation was to combine the use of Coumadin and mechanical devices. So next reference here, concludes exactly the opposite of the ACC position. The risk of postoperative bleeding episodes in patients taking warfarin was no higher than that in patients treated with placebo. And in general, bleeding rates were higher in patients who were treated with the low molecular weight heparins. Third reference, increased bleeding but not significantly different from low molecular weight heparins. Trend towards more bleeding with the heparins, and also no difference in regard to overall mortality or PE. And this study, though, was funded by Sanofi. Okay? And the last reference, of course, 7th edition. Now, move on to a different topic of mistake, faulty logic. Recommendation that the INR be kept between 2 and 3. Okay? There are no references. There's no studies to suggest that this is the proper number to use in orthopedic patients. Just most studies used this reference range. And they threaten, on the basis of this lack of information, that a lower INR may not provide optimal protection or even reduce the risk of bleeding, and again, no references. Faulty logic number 2, low molecular weight heparins are highly effective and safe. Are they really safe? Now, the ACCP admits the rate of major bleeding was higher if you started the heparin before, if you started the Lovenox, etc., before the surgery. And even admits that regardless of what time you start the heparin or the Lovenox, the rate of transfusion was higher in the Lovenox group than in other groups. But it's still highly effective and safe. Okay, next faulty logic. Multimodal strategies are likely to be effective, but they're more complex and costly than single modality options. Okay, well, let's look at that. Here are a couple of multimodality strategies. And so the study first combined Lovenox and the like with intermittent pneumatic compression or graduated compression stockings, the TEDHOs. And they found great decrease in the incidence of DVT with the compression devices. Then they looked also at aspirin by itself or aspirin with venous foot pumps, and found that the venous foot pumps were more effective when combined with the aspirin than the aspirin by itself. Now, most people would conclude that mechanical compression is a good thing, right? Not so the ACCP. Okay? They conclude that heparin, expensive, the Lovenox, expensive, their funding source is good, and aspirin is bad. So, is aspirin really bad? Not really. If you do, there's meta-analysis performed of 3-month all-cause mortality for hip and knee arthroplasty, and you'll see that aspirin and intermittent pneumatic compression was significantly lower than anything else. Right? So what's wrong with aspirin? What does the ACCP say about aspirin? With regard to hips, they make a 1A recommendation against the use of aspirin by itself. With regard to knees, they make a 1A recommendation against the use of aspirin by itself. And for hip fracture patients, again, a 1A recommendation against the use of aspirin. Okay. Next type of error, blind eye, where the ACCP is not looking at the data. I'll bring up one study in particular. This was preventing blood clots with a continuous enhanced circulation therapy versus low molecular weight heparins. Okay? Now, they used this device plus 100 milligrams of aspirin per day and compared it to Lovenox. And does this qualify? Let's use the ACCP criteria for qualifying studies. It was a head-to-head study with an established regimen of low molecular weight heparins. So it meets the comparator criteria. It used contrast venography, so it meets that criteria also. And dropouts were specified, 7 in each group. So yes, it does qualify. Further, it was published in 2006, in plenty of time for the ACCP to include it in their analysis. What did it show? It showed that it was more effective than low molecular weight heparins. 4 DVTs with the compression, 17 with the heparins. There was 1 PE in the Lovenox group and none in the compression group. And so again, you know, with the 100 milligrams of aspirin, it was a safe mechanism. They also say multimodal therapies are expensive. Not so. The use of CECT, if you include the treatment for the DVTs, saved the hospital on average $2,600 per patient. If that's expensive, I'd like more of it. Now, next blind eye is DVT is not a good proxy for pulmonary embolism. That's been an assumption that's been hammered into us for years and years. It is true of active cancer patients. It is not true of other patients for elective surgery. Now, in the Academy Guidelines, they clearly debunk this philosophy and using the same papers that are generally misquoted by the ACCP. Okay, go back to blind eye number 3, mechanical compression. The ACCP Guidelines state there's not a contemporary study that adequately describes the incidence of major bleeding in patients who have not received any prophylaxis. Remember, the only study that we have is 50 patients done years ago in Canada, okay? But the studies using mechanical compression all report an incidence of major bleeding of less than 1%. So in hip arthroplasty, ACCP recommends use of mechanical only in patients at high risk for bleeding. Even then, only until the bleeding risk goes down. Then you have to start one of their drugs. In knee replacement, it's okay if it's optimized, but again, it's only a grade 1B recommendation, but the high-dose heparins are grade 1A. And the saddest of all, I think, is the blind eye to the patient here. Because let's look at what is major and minor bleeding. Okay. Now, the Academy notes, and I've noted for many years, that the definition of major bleeding by the ACCP generally underestimates the bleeding risks. In short, the definition of major bleeding by the ACCP is about to die. Okay? Intracranial hemorrhage, retroperitoneal hemorrhage, enormous need for transfusions. These are major bleeding episodes. Everything else, it's just a minor bleeding episode, no big deal. But that's not true to the patient. My experience, 22 years of arthroplasty work, is that patients who have these so-called minor bleeds have more pain, slower progress in therapy, higher infection rate, and ultimate outcomes are less favorable, and there is considerable evidence in the orthopedic literature to support this as well. So what's the patient's concern? The patient's concern isn't all DVT. I think that any patient that we see who has a completely asymptomatic DVT couldn't care less. They were concerned about symptomatic DVT, and whether that's chronic lymphedema to fatal pulmonary embolism. This is what is the patient's concern. Shouldn't that be our concern as well? Okay. And so probably the patients couldn't care less if they had an asymptomatic DVT. And the last comment here on types of errors is political posturing. Now, the ACCP has been widely critical of the American Academy until the publication of the 9th edition. Okay. Now, the AAOS, the American Academy of Orthopedic Surgeons, literature was graded. They looked at much the same literature, and they rated the studies very differently. The hip studies, for example, only 2 were considered good, only 1 had wide applicability, and the quality of these studies was considered only fair. In these studies, all studies were rated as fair or poor. Only 3 studies with wide applicability, and those were all considered poor quality. So with the lack of good evidence in the literature, what does the American Academy of Orthopedic Surgeons say? Well, they say this. When only low quality or no evidence were available, guidelines were developed based on consensus of expert opinion and the best available evidence. Okay? Well, the chest guys don't like that very much. Okay? What do they say instead? They say, although the recommendations are evidence-based, we also provide expert consensus-based suggestions that clinicians might find useful when the evidence is weak. I don't know about you, but I can't tell the difference between these statements. Okay, does anybody? But what did they say about what did the chest guys say about the orthopedists? This is a slide from a talk, shall I say, from the other side, so to speak. And you notice the rating that the orthopedists are given in the upper right-hand corner. And they make this statement here that despite hundreds of randomized studies, orthopedists and other groups are threatening optimal benefits in key patient safety practices. And so the ACCP further misquotes the orthopedists. Right? They claim that we failed to show the benefit of any individual agent over no treatment. Blatantly inaccurate. And they also claim that the Academy's recommendations are all based on expert opinion. And the guidelines are the result, but the guidelines are also, they say, are not linked to the analysis. But that's not really the case. For example, the Academy excluded trials before 1995. Techniques were very different back then. Early ambulation is probably the most powerful tool that we have against blood clots, and people were not ambulated early before 1995. So that's not part of our analysis. They insist these are classic studies, you have to include them. I've already talked about expert opinion, and there really is clear linking. In other words, they see it this way. The problem is, where's the patient? Not in the discussion anymore. Okay. Do you buy it still? I don't. Now, I did not investigate every claim in the arthroplasty section, but I will tell you that every claim that I did investigate was faulty. So how could this happen? I'm going to turn outside of the field of orthopedics for a minute to a survey comparing Aspartame. And this was a meta-analysis done, and they looked at studies based on the funding source. And they found that 92% of unfunded or independently funded studies found safety issues with this widely used artificial sweetener, but 100% of industry-funded studies found it to be safe. Now, you look at the people who made the two guidelines that I've talked about. In the Academy, there are nine authors, all volunteers, and none had potential conflicts of interest. On the other hand, the ACCP, in the 8th edition, there are 7 authors, 6 disclosed at least one financial or intellectual conflict. So I think these words from Francis Bacon are relevant. And probably also these words from Ronald Reagan. Now, the CMS again has adopted the 8th edition guidelines, and so I question whether money has bought the government's experts as well. Now, I mentioned at the outset that this also is a personal issue. Okay, these are my parents dancing at an event for one of my kids a few years back. MSH at this time, 76-year-old white female, atrial fibrillation. Past medical history is significant for PMR, spinal stenosis, both of which have been treated on and off with moderate dose of steroids over the course of many years. And as a result of this, she demonstrated capillary fragility in the skin. This is what she looked like on September 11th of 2010. And for the medical students who may not have been exposed to this yet, you see a large hemorrhagic stroke. INR was 2.8, exactly where the ACCP says it should be. So what does this all mean? Now, if one guideline is so apparently dishonest, the odds are others serve the source of funding and not the patients. So the take-home messages here. 1, read the literature carefully and critically. Look at the whole picture of patient safety, and specifically with regard to the ACCP. With all due respect to Dr. Colwell, even water has to be monitored. Read and understand the guidelines pertinent to your patients, or so your patient, singular, one patient at a time. Understand the commercial bias in the guidelines, and cover your rear end here. Document why you're doing the right thing instead of the required thing. Now, remember, your patients are individuals. Do what is best for your patients, one patient at a time. And thank you very much.